that there are designated service providers who are big and they've been able to negotiate better terms for themselves to the exclusion of others. So the inquiry, part of the answer in the inquiry is exactly what the MEC was saying, that some of the service providers need to be organized because as sole practitioners, they are too weak. The problem is, you really are going to battle the other levels of this value chain are already concentrated. So the relationship is gonna remain unequal. That's why, for example, the smaller hospital, NHI National Hospital Network, we've allowed them to get together, in a sense, and collude, because it's the only way they can have a chance against the top three. And we see signs, they can do certain things together, they can purchase together, they can negotiate tariffs together. So it's the same thing with practitioners. So I think that it's possible that the designated service providers, some of them are favored. But let's deal with this issue of trying to equalize, and size is a very important factor in that. If I just add one thing on the supply side regulator, that what is envisaged here is really a comprehensive regulator that would be able, amongst other things, to determine tariffs. Because whilst it is true that a competitive public sector may drive prices down, but we know that that's not going to happen anytime soon. So the issue of tariffs has reached really a crisis level. Government has tried various initiatives to try and get an agreement on tariffs. Some providers and stakeholders have decided not to cooperate in that because they know that they are going to be worse off. So I think apart from standards and so on, there is the issue of price, and we accept that at the moment there is no constraint on pricing in the private sector, and so you need a very strong regulator to address that. And I would also just add on oncology, just for information really, that we have an investigation on cancer drugs. Cancer drugs prices are rising at an alarming pace. And we have a few excessive pricing investigations. They are very complex because a lot of information that we need is sitting with multinationals who are not here. When you call the local representative, they tell you that you can subpoena me, but I don't have the information. So this issue, I think, is probably getting less attention by, say, compared to, say, HIV/AIDS drugs. But when you look at the pricing and the margins that people are making, it's really alarming. I mean, I'll give you an example, and it's probably not something we should stop. Government is able to negotiate a price for the public healthcare system of the same drug that might be rebranded for the public sector, and we're seeing price differences in the order of magnitude of 200%, in some instances even close to 500%. Now, I'm not saying that government should not use its numbers to bargain, but those orders of magnitude are, I think, are an indication of some exploitation of those patients who are not covered within those drugs that are supplied to hospitals. So I think we have a particular problem with cancer. It is growing as a disease burden, but the costs are determined by multinationals. We have very little control over that, and I think we are going to need a national response at some stage on this. It's true of certain vaccines as well. I mean, because we are noticing that as soon as the state decide that they are going to vaccinate for a particular, I don't know, strain or whatever, the prices tend to go up very, very quickly. And again, these tend to be multinationals. So I mean, I think the issue about the number of people in medical aids being relatively stable and prices increasing was just a comment, and I agree with that. I think that we, I mean, it confirms the point about price increases in so many levels of this. We call it market, you could call it system or something else, but there are many examples and many benchmarks you could use. In fact, the fact that medical aid numbers are not increasing is in itself a problem, because recall that even though we have high levels of unemployment, the numbers of people who are employed in real terms has been increasing. So if you look at the numbers from about 1994, you just look at not the percentage, the actual number of workers, it should give you more people on medical aid. But why are they not there? I think is a very interesting question.